You know how when you go through videos about sports hernias and read articles, there's a big mystery involved with it. They're talking about the groin pain or lower abdominal area that is maybe a fray or a tear of a structure or a soft tissue or whatever, and nobody really gives you really any answers. Well, in this video today, we're going to cover based upon what current research talks about with symptom generating structures involving sports hernias and contributing factors that are not really symptom generators, but parts of the puzzle for people experiencing lower abdominal and groin pain. This video is going to be a wealth of knowledge for those of you struggling with this problem, so make sure to like it and save it to your library. Hey everyone, I'm Sebastian at Performance Play Sports Care, part of the locally world famous chiropractors in Costa Mesa, California. Now, all of the research that I'm using as a reference is in a link in the description below for this video, as well as ways to contact us if you want any help from us directly. Now, we're going to be using pictures, models to understand a little bit more about the structures because me demonstrating on myself really isn't going to do its justice. Now, the structures we need to be considerate of when dealing with something like a sports hernia are, number one, it's the conjoined tendon or aponeurosis that becomes the conjoined tendon of the internal oblique muscle and the transverse abdominis muscle. We also need to be aware about the pubic symphysis. Again, I'll show you on a model. And the third thing is the nerves that pass through the area, which for historically, this has been something that's been overlooked in management of these conditions. First thing we're going to cover is the conjoined tendon. In the anatomy book, this is called Netter's anatomy. This is one of the gold standards of at least anatomy books around. It's been around for decades. There's pictures for free online. I'm sure you can find them. So you can look up Netter's and abdominal wall or internal oblique or something of that nature, and you'll probably find this exact picture. Now, this is the front of the body, and we're going to start going down in layers a little bit just so you can get a better reference point of where things are at and so on. So you can see this is the side of the body here, and we've actually cut a section of the body off called the external oblique, which is part of the abdominal musculature. This is on the outside, so it's on the external. The next layer down is what we call the internal oblique, which is the red layer you see here. The white is where it becomes a little bit more fibrous or into fascia and then into tendons and so on. And then you can't see the transverse abdominis, which is the deepest layer here, which is a big part of a concern for people with lower abdominal pain and groin pain. But you do see down here, this is what we call the conjoined tendon. Right into here, the conjoined tendon conjoins the internal oblique and the transverse abdominis, and it actually moves into this area and this area. So it moves into the side wall of the six-pack muscle. I'll show you on a different picture, and it also moves down into the pubic bone. So those sections are what we're talking about when we were talking about the conjoined tendon. Now let's see how they actually come in together on another picture. Now this one's a great view. Again, another Netter's picture here. This is actually the left side of the body here. Here's the femur, here's the abdominal wall again right here, and we've just kind of narrowed the view a little bit here, okay? There's the six-pack muscles that runs up and down. It's just been cut away. And then there's the pubic bone right here. Pubic symphysis right there, which we'll talk about a little bit later. Just the section between the two hoops here. Now, we see the external oblique here again, okay? We also see the internal oblique just deep to it, and then we see the transverse abdominis. And as you can trace these guys down here, the transverse abdominis and the internal oblique, they start to get a little white, so a little bit more tendony, fibrous-y, aponeurosis-y, and then they come into what this section right here. Again, if you look down at the word, it is the conjoined tendon here as it inserts into kind of everything into the abdominal area, the rectus abdominis in the midline. It also does travel down. It has another section that travels down to the pubic symphysis. Now, although we can talk about symptom generating structures, as you can see, things become other things. So you can't really just blame only the transverse abdominis. You can't only blame the conjoined tendon. Things intersect into other things. And as we have learned, at least with anatomy, when you're dissecting things down in dissection, it's hard to separate things because everything does work together and they become other things, right? So we're going to get to one more picture here to show from a cross-sectional view, it's like if you cut me in half here, what this actually looks like from that view. This one is also available online too, and this one is great to see, again, how those tendons come together right here. So again, this is like you slice me in half and you're looking straight down. Okay, so this is the transverse abdominis, the deepest core muscle. We have the internal oblique, the middle, and then the external, which again becomes the tendon. It's all one tendon here. It's all one fascia tendon mix. In case you're wondering about like fascia covers everything. It covers muscles and tendons and ligaments and organs and so on. And so you can't really separate those two either. It's like a saran wrap on top of everything. But you can even see that the external oblique comes into the same tendon as well. So when we're talking about the conjoined tendon and the aponeurosis, it's essentially that interface into there. For a lot of people who have this condition, if it's higher up into their abdominal area, like up into like here, then it's going to be a little bit more of possibly this one that goes that way. But for people who have problems where it's more deeper here, it could be the section that's going into the pubic symphysis and the interplay between the symphysis and those structures as well. The adductor tendon too, in case you didn't see on the picture already, it actually jumps off the pubic bone and goes down too. And part of its fibrous network is continuous with what we just saw. It's the same thing, but an extension of it as it becomes another muscle. Now let's take a look at the pubic symphysis. The pubic symphysis does have nerve innervation. It is a joint. It's more of a stiffer joint than the cartilage of other joints called fibrocartilage. And so it does have sensory, all right? So if you create a little bit of irritation of it, it can create sensitivity in the area. Some of you who may have had this before, you may have been told you have osteitis pubis, which is still part of the puzzle. And this is kind of why sports hernia is a little bit challenging, because we're all kind of arguing about which exact structure it is, when really the symptom generating structure may change based upon the mechanics and the workload that you put on it. Your body's trying to compensate. And I'll explain that a little bit later as we go through things too. So the pubic symphysis here, this picture right here is the same one that we just saw a little earlier. And then we have the middle joint right here. You can see pubic symphysis. It's covered by some of the fibers of the external oblique or the aponeurosis. So it's covered by some of the stuff that we talk about as possibly being frayed, torn, and so on. And so it's right there, and if we move this picture around, you can see that actually now it becomes a little bit more joint, because we have the fibrous tissue dissected away, and we also have this one right here, and you can see that the adductor tendon is inserted directly just next to it, and everything that we looked at prior actually comes into it as well. So all of that does work together, but the possibility of having sensitivity of the actual joint, the actual pubic symphysis, is a possibility. And I'm not saying that either one of these is going to be the culprit with you, and maybe a little bit of both, and it may be a little bit of the next one we talk about is the nerve. But these are the possibilities of symptom generating structures in that area. Now the last one we have that we can again see on the netters and a bunch of pictures online is the nerve part. They finally started to add some of this consideration into some of the research. In years past, they really couldn't explain like the testicular tightness. It was hard to identify why people may be having pain despite really not having any imaging finding of tissue disruption. Like there's no tear in the fascia, there's no tear in the tendon, there's no adductor that's ripped off the bone, although there may be a little bit of bone marrow edema. And they couldn't really identify anything on images, so they're wondering what the heck could the pain aspect be. And this could, or pain, or just altered sensation. And this explains part of that, and I can be a testament of this with a lot of the people that I see with this, is that sometimes when you address the nerve part, a lot of the sensitivity and the pain goes down. It doesn't resolve some of the contributing factors, but it certainly can help out with pain. Now, with this here, you can see all these yellow parts are basically nerves, all right? We have the external oblique, we have all that fascia, we have these nerves kind of jump into different regions here, and I'll show you on the side here of kind of where they, what they're called and where they derive from, so you can get a better idea of if you want to look more up on your own, and we do have other videos on YouTube on this as well. And so first off, the testicular tightness here, and so there's nerves that go down into the testicles, right around from L1, L2. This is called the genital branch, the genitofemoral nerve. This nerve actually goes through the psoas muscle, which goes through your pelvis, which we're not really showing on here. And we also have all these little other ones too. The femoral branch, the genitofemoral nerve, which is L1, L2. We also have the lateral cutaneous nerve of the thigh right here, which can be part of like the sensation that goes down to the thigh for some people. And then we have the lower abdominal one here, which is the iliohypogastric nerve, as it pierces out of the fascia and just runs underneath the skin. So some of the people who have these problems, like there's more just sensitivity than anything else. They have no loss of strength. These ones are sensory nerves. I'm trying to recall, I don't believe there's any actual motor branch of them. And the difference of actually motor and sensory is at least in regards to depth, typically as it goes, and here's the skin layer and here's the deeper stuff, like the muscles are down here. As nerves run to where they're going to run, they basically become, there's a motor branch which comes down and it innervates the muscles, which can create contractions like, you know, me moving my fingers or you flexing your hip. And when they've been compromised, sometimes people end up having motor loss. And motor loss is like weakness, I can't use a leg. When you go to a provider, they can actually test to see if there's any motor loss as well. And sometimes there's no motor loss. And in that case, there's a possibility that just more in the layers here, which is the fascial layers of the skin layer, there could be an issue more of the sensory branch that comes up. And so that kind of provides the phenomena where people really don't have any real motor loss. There's no function change, but man, it hurts like heck. And those sensory branches is what gets like the feel of like when you go like this, you're like you can feel your skin, you can feel the rubbing, you can feel like light touch or pressure. And they also send other sensations to the brain too. So those can attribute to part of the pain aspect of the problem, even though the imaging findings may be negative. Now that we're aware of possible symptom-generating structures, let's go over the part that's actually the most important. How do we stop this madness from reoccurring? We know that the body works together as a one big unit. You saw in the images that things become other things. Muscles become tendons that move into fascia, that become other tendons, that become other muscles as they start to create these sling systems. So ideally, if we learn about the way the body is compensating and why it's compensating that way, we can better learn of how to get out of this whole mess and stop the reoccurrence, which is the major issue. So now I'm going to cover some of the findings in another article I have, and I'm going to post in the description as well. It covers mainly groin pain in athletes. This is not only specific to sports hernias, full transparency, but since the whole area works together, it is an important part, and I think this is a variable that's going to come to the forefront at some point when managing sports hernias. In this article, they actually took many different articles and compiled them into a little tiny bundle and figured out which ones suggest strong evidence for certain aspects of groin pain, moderate and weak or limited. To be fair, not everything that's been studied has been studied, so that's why limited evidence may mean not currently supporting right now, but it doesn't mean it may not be part of it later too. But here's what we do know. Taking your fists and squeezing like this, if you have pain with this, it'd be reasonable to say that you may have pain later as you start to re-engage in activity. So although you're taking time off of activity and it feels okay, as you start to squeeze here a little bit and you start to notice that the symptoms returning, or you notice that it's a little bit achy or stiff or different, as we kind of say, it feels odd, that's an indicator that there's a possibility that it may return with sport. Not to say you can't get rid of it, but it's something that we can use as a possible indicator. It has a strong relationship to it. Another one that's really important is a lack of hip internal rotation. What that looks like here is we examine, and me, Don, and Mandy have all gone through these tests on YouTube before with everybody, but it's basically 90 degrees, and then you spin your foot out. Usually we do it passively with people. We do it for them. And so this is hip internal rotation. External rotation, as we'll find out later, actually has a weak relationship. It doesn't really matter too much, or at least evidence doesn't support it right now. The important takeaway from this and the next things that I'll talk about is that these are things that are not painful but don't work. It's a limited range. I'm not by any means saying go find the latest and greatest mobility video for internal rotation on YouTube, because there may be a reason why it's limited. There might be a bony block, there might be an old labral injury. So there's a lot of reasons why this could be happening, but the limitation in range, whether due to osteoarthritis or even a labrum, is not always painful. It's just limited. But we do know there's a strong relationship with a limitation of hip range of motion in relationship to groin pain or possible future onset. Before we go too far in the video, just let you guys know there is a free webinar in the corner that we made just for you for groin pain. All right, there's a lot of misconceptions about groin pain. I'm covering some of them in this video, but because we make so many videos on YouTube, we really always can't create fun graphics and everything to them. It just becomes a little bit daunting and time constraints and costly. And so we spent a bit of money on that, and we tried to make it fun, to the point, super informative, so you can get the care that you need. So take advantage of it if you haven't watched it already. It does cover things like sports hernias and other types of groin pain. Another test, which is going to be different side to side, is a bent knee fallout. Again, it's not always painful on people, so it's going to be here, and so it's going to be just like so. So the people who may have more of a positive test on this, their good side is going to be kind of like so, or some variant of kind of like a quote-unquote normal, and their other side is going to be kind of like this. Again, it may not be painful. I cannot stress this enough. Pain is not an indicator on these. It's a lack of function or range, and that's why dysfunctional, non-painful areas are a really good, simple way to help decrease possibility of flare-up, and things that you should probably be working on when you're remedying this problem anyways. Next, we start to look at the core. The core has a relationship in this, and we do know, based upon the aponeurosis and the conjoint tendon, that actually when intra-abdominal pressure within the abdominal cavity, as it increases and spikes with normal activity, especially sporting activity, there's a shudder effect where it may be too much for that tendon because the force distribution throughout of it is not good. Okay, the transverse abdominis has a big part in this. All right, and as we're going to see through the next three things that I'll mention here, the transverse abdominis is best conditioned, by the way, through diaphragmatic breathing, which is coached very specifically with a lot of these pressure cues that we use in a lot of our YouTube videos, and we see people for with either virtually or in person. So you don't need to suck your belly button in. I cannot stress that enough. It is not a hollowing that helps out with the transverse abdominis. That was old literature. Now it's more of an outward pressure. So in this study, they attached an electromyogram, so electrodiagnostics essentially, to the rectus femoris, which is the muscle that goes from the thigh all the way down in the center. It's the two-joint muscle. We also have the external oblique, which we saw in the picture, the internal oblique, and the transverse abdominis, the deepest of the core. And so what they found was that they started to do a single leg raise, which I know a lot of people that we manage with lower abdominal pain and groin pain, this is a test that they don't like. They also don't like this one either, just sitting up. But this is something they continually reduplicate. And so the answer is not do more of them. The answer is do the type better. Because what they found in the study was that there was a latency of contraction of the transverse abdominis, meaning the transverse abdominis was not helping. It wasn't part of the game. The transverse abdominis, again, it becomes part of that conjoint tendon, right? And so one easy thing you can do is create pressure outward. Again, this is not hollowing. It's more of a diaphragmatic type of approach for core pressure. And then you can do the same activity too. And for a lot of people, when they go really slow and they monitor the pressure, it increases the transverse abdominal activity, especially early in the activity, even on break, and it decreases the amount of function or the overdominance or overuse of the rectus femoris, or in theory, some of the other groin musculature too. So it helps normalize the scenario. Next, a really awesome study they did was an ultrasound study to visualize, is there anything different about the transverse abdominis versus the external oblique, with something simple like the single leg raise test like we just did, but also they did something really cool, which is they did this test, because this is what bothers people, right? This is probably one of the most common tests that people do when they come in with groin pain and some lower abdominal, other than the sit-up test. Okay, so what they did was they did the two tests here and here, and they actually visualized and saw on the ultrasound what the difference of size was of the musculature. And what they found in the literature was that there was more thinness. It was a thinner transverse abdominis versus the internal oblique on people who had symptoms versus those that didn't. So it was mainly found at rest. It wasn't during the activity, which is kind of interesting. We'd have to figure out how that relates to things a little later. But overall, there was a thinner transverse abdominis. So there's more in the study that you can look up for yourself, but I think those two studies in themselves are really nice to see. Number one, the transverse abdominis was late to the game, indicating core function was altered. Number two is that they actually visualized to see the transverse abdominis was actually thinner, meaning the core was altered. The core is part of this, and not just the core, it's actually affects the function of the core, which is actually the pressure. We talked about the shutter effect. The shutter effect on the area that generates the symptoms, which is the aponeurosis or the conjoint tendon, and the excessive tension that it may get on it, and at some point it may be so much tension that it actually tears or frays. But for those of you with a negative image, if it hasn't actually torn or frayed yet, maybe it's just enough just to make it sensitive. And the easiest way to decrease the amount of tension on it is take the workload off of it and normalize internal pressure, which is monitored ideally and taught with diaphragmatic breathing, something like a dynamic neuromuscular stabilization approach, in my opinion, or my bias, but there's other ways to do it too. But we do know that hip internal rotation is part of it. We do, or a lack of hip internal rotation. We do know that adductor strength is part of it, and we do know that the core is part of it. And these are things on people that are not necessarily painful. They're things that you can do despite being in pain, but if you're under care for your pain, you can also work on these too. So there are a few ways to manage the problem: reduce the pain and work on contributing factors. So the things that had a moderate relationship to people with groin pain, and I think possibly sports hernias, it was interesting, the radiology finding. There's really only two of them. The radiology findings were mainly associated to MRIs, and one of them was a finding of bone marrow edema in the pubic bone, or in the hoop down at the bottom, as we saw in those pictures. So bone marrow edema can be found as a brighter signal on a T2 image. You can find endless references of it on Dr. Google. And then the other one was a cleft sign. It's a line or a lucency through the area, which basically is the attachment point for the adductor tendon as it goes into the little hoop thing as well. So the reason why it was moderate, again, because they found that people who had bone marrow edema had groin pain, but also those who had it also didn't have groin pain. So where do you draw the line? It was kind of like supporting and not supporting. And the same thing with cleft sign as well. Now the things that had limited evidence, at least at this time, according to this study, again, the link is in the description, you do your own reading and due diligence. Not to say they will ever have support or they'll never be part of it, it's just that it hasn't really been shown to have a stronger amount of evidence. And it's important to realize, at least we're talking about evidence, there's things that have support of, and there's things that haven't really been looked at yet, or hasn't been looked at in good detail. And so the things that are in this category may not be the first things that we want to focus on just yet. Okay? Hip external rotation, a limitation of hip external rotation was not really strongly related, as I demonstrated earlier. Internal is. The next thing that was interesting that really wasn't super related was x-ray findings of the pelvis. You'd think that you'd find something on an x-ray and it would show you what's going on, but not really supported this time. And also too, which I think is way more interesting, was hip impingement. So femoral acetabular impingement, either from cam or pincer deformities. These things are actually really commonly found in athletic populations. The theory is that they actually grow and become more of at least the cam is the more common one. And so the femoral head is like a ball. Instead of a ball, it becomes oblong. Oblong is kind of like egg-ish. And so it's not really like the cleanest orientations, they say. And so findings of that on x-ray are more common in athletic populations, and we theorize it's based upon people who are more athletic at a younger age prior to their growth plates coming together and fusing. Okay? And so that oblong shape may be an adaptation, just like baseball throwers, if you throw a lot when you're younger, prepubescent, you may have a lack of internal rotation, and you'll have greater external rotation, but overall the set point is the same, it's 180. So it's an adaptation. It may not be a super big indicator of groin pain, essentially, but it's interesting because a lot of people that we see at Performance Place here, they're really, really concerned about their hip impingement findings on x-ray and also things like labral tears. And it's because they've been through enough providers that think it's a strong relationship to it, and they believe that if you actually resurface the hip or you sew the labrum back up, then it solves the problem. Again, I think these are possibly going to be part of it in the future, but I don't think you'll have to surgically repair them, because what happens is sometimes a labral tear will come from, I believe, from excessive hip impingement and pinching pain in the groin, right? It'll just start beating up on it a little bit, which also limits hip internal rotation, right? And then there's that, we already know that's related. So I think there's a possibility this may come a little bit more forefront, but at this point in time, I don't think there's any big reason to actually say that hip impingement signs on an x-ray I know it doesn't say labrum, but I don't think a labrum finding on an x-ray, a small one, is really a big deal. And the last thing is signs of cartilage degrade. There's two signs that you can look at on blood work, which is COMP, and CRP, which is C-reactive protein. Personally, I don't do a bunch of blood work with the people that I see, but the thought is that if the cartilage is degrading or signs of it in the blood work, then maybe this is arthritic formation. You have your quote-unquote bone on bone, which may be creating the groin pain. At this point, it doesn't look like it's really super related, and I like that, because what are you really going to do if your cartilage starts to degrade? It's something that's, I think, has a really bad name, degenerative joint disease. It sounds like it's an ever-going thing that's never going to go away, and I think that's completely false. It's a sign of how you use your body, which is a sign of past trauma. Now let's summarize things here. We know that there's 3 possible symptom generators for a sports hernia, or lower abdominal pain, whatever you want to call it. It's going to be, number 1, some type of soft tissue, which is probably going to be related to the conjoint tendon, the aponeurosis as it comes into the conjoint tendon, or as the conjoint tendon starts to move into the rectus abdominis sheath, or as it goes down into the pubic bone, and then it kind of becomes the conjoint tendon of the adductor. So it's going to be that section there. If I had to take a good guess, I think it's going to be, for most people, it's going to be where it inserts into the pubic bone at the top, okay? The second option is going to be with the pubic symphysis excessive shear force. In other videos, we did cover that a lack of hip internal rotation shifts the workload to an adjacent joint, in this case the pubic bone at the pubic symphysis, and too much shear can create irritation at the joint just like any other joint, and it creates pain. Also, too, the adductors and the other things attaching to the pubic bone may work extra to stabilize now and become extra active. The third thing is that we have the possibility of the nerves passing through the area, creating some of the pain, but not necessarily finding a positive image of it, because nerves are so small. Usually those little guys, the sensory ones, aren't really easy to see on images or ultrasounds. So if you guys like this video, please come see us. We specialize in seeing people with sports hernias and other types of groin pain. We do a good physical exam, we do a good movement assessment, and then we don't suggest exercises by guessing, okay? We test each exercise. Exercises do not need to hurt to be productive. Stretches don't either. Usually finding a way to coach the body out of the painful compensation is the way to go. And for that reason, the exercises end up being hard, not painful. Sometimes we'll find that the target tissues, like if we're trying to work the glute max, we'll find the glute max is a little bit hard to turn on. We'll get it to turn on, and then the expression is a really hard glute exercise. But you shouldn't have to fight through groin pain to get that. If you are, you're missing an easy win. So reach out to us. We have our link in the description below. Take advantage of the webinar and subscribe to the channel for more videos just like this. See you soon.